So whenever there is a refractive surprise after we've done a cataract surgery, we have to just go back and see what was the problem. Is it on purpose? Hello?
Hello?
Can you hear me? Yes. Okay. So we have to just go back and see what was the problem. Why did we have this refractive surprise? Was it a small eye? Was it because it was a myopic large eye? Was it because it was a failure of your biometry? Because it was a dense white brunescent cataract and there was a low SNR. So then you have to find out whether it was the incorrect IOL formula which you used, or was it a error in the data entry, not the right lens that was given to you in the OR. So any which way, these are a couple of ideas on why we need to do a good biometry, and these are certain tips that errors can happen due to the excess indentation of the cornea. So whenever you're doing an indentation method of your biometry axial A scans, just see that you just touch the center of the cornea, don't indent it too much. And non-contact methods are always better and give you better results also. And biometry choice, always measure both the eyes in case you have a refractive surprise, or you've done your biometry and you've seen that there is a lot of discrepancies, then just go back. So we'll just go into the management. If it's a small error, you can suggest glasses to your patients, and if they're happy with it, then you're done with. If not, you can suggest contact lenses. If there's a astigmatic problem, if you feel that you could, it could be taken care of by limbal incisions or some corneal relaxing incisions, which are very unpredictable. You can do it. A LASIK correction would be another situation where you can manage it, or you can do an IOL exchange or a piggyback IOL. So this is the case number 1 where we had to exchange the IOL. The lens was in the eye, and this was operated a while ago. Patient was an outstation patient. He came back and there was a refractive surprise. Now here, the later you do, the more gentler you have to be. You have to remember there is a lot of fibrosis that has happened between the anterior capsule and the lens. So very slowly with a Lester's hook, put adequate OVD, and you need to just raise the capsule around the IOL very gently. Once that is done, put in more viscoelastic and nudge the lens. If you see that the lens is moving without causing much force onto the zonules, again put in more viscoelastic and lift the lens to prolapse it into the anterior chamber very gently. First the first haptic, and then you need to put in more viscoelastic, lift it again gently and place the lens inside the anterior chamber, once over the anterior capsule. Once you've done that, so have to always be careful. It has to be very gentle maneuvering, because you don't want any force on the zonules. And the technique which I do is the scaffold technique. Once I've placed it onto the anterior capsule, I put in the intended IOL inside the bag. It's easy to dial it in. Once you've dialed it in very gradually under this lens which needs to be exchanged, now you're at least sure that your posterior capsule is well guarded. Put in more viscoelastic, and with this cutter, you can, left hand or your non-dominant hand, you support the lens, and then you cut the lens with the main port, and you can cut it into smaller bits and gently take out the lens. If you feel that the second piece is a little bigger, you can recut it and it comes out very easily. And every time you doing this maneuver, see that you have good viscoelastic coating your endothelium, and then you can do this very successfully. This is another case where the IOL, it was a Toric IOL, and then the lens, we had a refractive surprise. We put it through the Toric calculator and we realized that we need to rotate this lens. Again, we need to just scrape off or release all these fibrotic adhesions between the anterior capsule as well as the lens, the IOL, and viscoelastic, which we can put slowly, gradually under the capsule and release these adhesions. Once we see that the lenses, do it all around, And once you see that the lens is mobile and it is moving a bit freely, then you can redial this lens into position. But all these maneuvers have to be done gently, and the earlier you realize that there is a refractive surprise and you deal with this, the easier the surgery is. And only thing is you need to counsel your patient well. This is another patient where there was a refractive surprise, there was an astigmatism, and the haptic was not in the bag. So very gently viscoelastic was put, and both of the haptics are now in the bag, and the situation has been resolved. So basically, we need to have a good biometry tool, and our future lies with a flawless biometry. We are getting more and more close to this flawless biometry. And post-operatively, we need a lens where we can touch up according to, age of the patient, requirement of the patient, and gradually give the patient the optimal sight which we had, promised. And the most exciting technology is by, it's developing by the femtosecond laser. It's in the priority method now, proprietary method now. So this is going to be changing, a game changer in our IOL practice as well. Thank you very much.
Thank you so much for the patient listening, everybody. And with this, we conclude the IC. And I hope we've given you a tip or two to dodge the bullet when it comes in your OR.